Hi, everybody. Welcome. We'll give it a few minutes for other people to join us. For those of you who are, please go ahead and say hey in the chat. Let us know where you're from. We're excited you're here.
Yeah, I'd love to hear where people are from and what your role is at your hospital, if you'd like to put that in the chat.
Hi, Aria. All right, for those of you just joining us, we'll get started in just a minute. Please take a moment to say hey in the chat. We'd love to hear what site you're from and what your role is at your hospital.
I see Katie Bell, and I just have to say hi to Katie Bell. Hello, Katie Bell. One of the first great conversations I ever had in addiction medicine.
Katie, we're glad you can join us today. I see we've got Rebecca Harris, our son at Mercy Folsom. Welcome, Rebecca. Hi, Christina, ED Director from PAH Health Downey Hospital. Awesome. Glad you could be here. Elaine, hope I got that right. Psychiatric RN. Fantastic. Glad you're here. Abby, son from Cedars-Sinai. Fantastic. All right. Fantastic. Glad you guys are all joining us. Hi, Melissa. Hi, Sarah. All right, let's see. Let's give it like another 30 seconds or so, just for those folks sliding in right at start time. Our Denise, San Bernardino, or excuse me, St. Bernardine. Thank you. Glad you're here. All right. Well, welcome everybody. We're so glad you could join us today. Today is a very special event, our Innovations in Nursing special event, case-based learning. Today we have members of the whole nursing team, and we're going to be discussing specific patient scenarios, reviewing cases. We'll explore what went well and what can be improved upon. And we'd love to hear from you all. So this is an opportunity for you to chime in the chat with any questions along the way. There's also going to be a point about halfway through where we can pause and invite anyone who's available to share a specific case that they may want to discuss with the panel, or just found themselves wondering what went right and what went wrong and want some reflection on that. This session is being recorded and will be made available to you later. Closed captioning is available for those interested. And now I'd like to turn this over to Tana. Tana.
Hi, thank you, Amy. Well, I just want to welcome you all and thank you for joining us today. I look forward to spending this next hour with you. My name is Tana Brooks. I am a nurse advisor for the California Bridge program, and I'm also an emergency department charge nurse. I've been practicing as a nurse for about sorry, I'm like fumbling over my words. I've been in the ER about 5 years, but a nurse 9 years, and worked in inpatient settings in tele and critical care. And with that, I'll let the other panelists introduce themselves as well.
Hi, my name is John Bresson. I'm a nurse practitioner advisor for the California Bridge program. I also work in an emergency department, and I bring 18 years of practice as an NP in the emergency department and trauma settings.
All right, my name is Shannon Koenig. I'm a nurse practitioner advisor for California Bridge, and also practicing as a nurse practitioner in the emergency department setting. I've been a nurse practitioner for about 14 years in a variety of settings.
And I'm Ariana Campbell. I am a PA, and I have been a PA for 21 years and in the emergency department for 19 years of those. I actually work with Tana and at a community hospital, rural hospital in the foothills of Northern California. And I am here today because I made a big mistake when I started a program at my hospital 4 years ago. So just for context, I practiced for 17 years without what I say, giving the right medication to the right patient at the right time in the emergency department for folks who are struggling with opioid use disorder and withdrawal. And I started a program just trying to give the right medication and then discovered that I didn't include the nurses. So I didn't educate, I didn't let anybody know what I was doing, and that was a really big mistake. And I've been trying to make it better since. So I'm just really happy to be here today and really happy to go through cases, because for me, when I'm attending anything, if there's cases, it makes it feel real to me. And so I identify with cases. So I'm very excited to review these cases with this amazing panel today. So thanks.
Thanks, Ariana. So like we've been saying, we're going to introduce the California Bridge model of care, and then we'll be talking through 3 different cases. We'll stop for opportunities for questions and comments at the end of each case. And then after the first 3, we're going to pause and see if anyone has brought any cases that they would like to discuss. And then we'll move on to a few more cases if time allows. So again, just please place any reactions, comments, questions you have in the chat as we go along. We really want to engage with you and make this as interactive as possible. With that, I'm going to hand it over to Ariana to introduce our model of care.
All right, it's my favorite thing to do to introduce the California Bridge model. So just to start out with, we are a program of the Public Health Institute. I am paid by California Bridge as a director, as we all are in our roles, but we otherwise don't have any disclosures. And sometimes I have to really emphasize that, because we're so passionate about this type of care that sometimes it may seem like, is a pharmaceutical company paying us? No, we are just very passionate about providing evidence-based care to our patients struggling with substance use disorders, specifically opioid use disorder, in the emergency department. In terms of our reach, the next slide, I'm so proud of this picture of the state of California, which our presence is growing. So our goal is that a patient can wake up in the morning and decide to get treatment, and just know that they can go to their local emergency department and get high quality evidence-based care. Just like if they had a bad cut to their hand, they would say, oh, I go to the emergency department for that. So our goal is to have the same type of access for any patient who wants care for opioid use disorder, for really any substance use disorder. And this is by 2025. So in terms of our progress, we started out, I think, 4 years, 3.5 years ago, just with some technical assistance to 8 hospitals. But we did a project over a 15-month period of time with 52 hospitals that was very successful in implementing programs to treat folks. And then our update is now there's 132 hospitals implementing the model that we're going to talk about and providing care very similar, or hopefully learning from the cases that we talk about today. And soon, hopefully, we'll be up to the 206 hospitals that are funded to do this work, and with recent indications for funding for every hospital in California. So we are well on our way there to our dream of universal access to care in California. And this is the model. We try to keep it pretty simple. I know when I started the program in my emergency department, we didn't have to wait for everything to be perfect. We wanted patients to have access to care. So this is low barrier treatment. This is somebody literally being able to come to the emergency department or hospital and be able to receive the right medication at the right time, okay? And we want to have a program in place so that they are connected to care, to high quality care in the community, and to any community resources. So I always say trying to bring all of those resources that are available and sometimes siloed to the patient in front of you. And then through all of this work, we are developing a culture of harm reduction. So that's not just naloxone access, but most of our hospitals do have access to naloxone. We literally hand patients naloxone prior to leaving the emergency department or hospital, but it's an entire way of being. It's meeting patients where they're at. It's reducing the harms to them in many ways. And sometimes that is just treating somebody with respect, with compassion, and with reassurance that you're going to help them. So I just want to emphasize that sometimes it's how we look at a patient, how we talk to a patient, that also reduces harm. All right, and I think now I'll turn it over to Tana to talk about addiction in general, our premise.
Thanks, Ariana. So I'd like to do like a quick check-in and set our perspective as we launch into these case studies. And one of the very most important things to remember is that addiction is not a moral failing. It is a chronic disease that requires medical treatment. And you'll see this concept laced throughout our case studies today, but it's just something that is so important and valuable to all of us here to just remember how we're treating our patients. And then next, also to remember that we want to utilize person first language, and this how we actually speak about patients or to patients really influences how we think about them and how we interact and treat with them. So just wanted to do a quick check-in so that we can remember what terms are important to use and what terms not to use. So terms to use, like person who uses drugs, a person with a substance use disorder or with an opioid use disorder, and then avoiding terms like addict, user, junkie, or druggie. These help us remember that a person is a person first, and a behavior is something that can be changed. All right, we are going to jump into our case studies. These cases are examples of situations that we have seen at a variety of our bridge sites. All of the patient identifiers, as well as some minor details, have been modified in order to protect the privacy of our patients. With that, John will be presenting the first one. So John, take it away.
Thanks, Tana. This first case is Rashad. He is a 26-year-old male patient that comes to the emergency department and asks for help from withdrawal from heroin. He was recently seen the prior week at a local area hospital for the same complaint, and he was prescribed clonidine 0.1 milligrams daily, lorazepam 1 milligram twice daily, and ondansetron 4 milligrams sublingually as needed for nausea. He states his last heroin use was approximately 8 hours ago. He does have some minor symptoms like goose flesh, anxiety, restlessness, nausea, and some mild pupillary dilation. Go ahead, next slide. So he's mildly anxious, restless in triage, and states that his last heroin was 8 hours ago. So go to the next slide, please. So, sorry, his initial dose of buprenorphine was 8 milligrams sublingual. He was reassessed in approximately 30 to 45 minutes. I tend to like to reevaluate them at 20 to 30 minutes. But his symptoms have improved, but he's mildly restless with some residual nausea. I gave him a second dose of buprenorphine sublingually. And the patient, after a short period of reevaluation, his symptoms have completely resolved. The patient was sent home with a prescription for buprenorphine. He was connected with our son and planned follow-up with clinic as an outpatient. So interesting case that, you know, old therapies do not work. Buprenorphine is, of course, the drug of choice. And the treatment is very simple. It's easy to do in the emergency department. Don't you agree, Tana?
Yeah, no, I think that case definitely highlights how, you know, a patient got one method of treatment and he actually came back because it wasn't working very well for him. And then getting him the right treatment at the right time really made a big difference for this patient. And I think this shows how simple and straightforward it is, which is really cool.
And it's interesting because most people will tend to use a COWS scale. And you don't really need to use that. You really just need to trust your patient, that you really know how they're feeling, and just know that when they come in and they tell you that, you know, they're withdrawing, that they are withdrawing. So trust the patient's self-report. I think that's key as well. It helps identify them as a person as well and talk to them as a person and believe them that they are in withdrawals.
Yeah, I know they've looked at comparing a patient's self-report of how severe their symptoms are and comparing it with the a little bit more objective COWS scale, and it follows a similar trend. Like if a patient is in severe withdrawal, they'll tell you, and they're not lying about it to try to get buprenorphine. So,
yep.
All right.
All right, so just some brief signs and symptoms of acute opioid withdrawal. So the patient will tell you, man, this is the worst flu ever, or I feel like I'm kicking, or I'm dope sick. They can be very restless or even agitated while you're interviewing them. Definitely, they're going to say, I ache all over, all my joints feel terrible. Mm-hmm. They could have some nausea and some abdominal clamps, and they will tell you that they feel hot and cold. Some objective signs is when you're looking at the patient, they are unable to sit still, or they could be very agitated. Sometimes they're tachycardic. Sometimes they're visibly diaphoretic. You look at their eyes, they may have dilated pupil. They also can be have some rhinorrhea, so they're sniffing a lot. They also could be having vomiting and diarrhea, and they may yawn, and that's one of the kind of subtle signs to pick up on when they're talking to you. And then, of course, the goosebumps or piloerection that you see. So definitely some hard signs there.
Yeah. And then Artemis says the history of use can help indicate the severity of withdrawal symptoms. That's very true. Thank you for pointing that out. Any other questions or thoughts on this case?
This is Ariana. I was following that the history of use can indicate the severity of withdrawal symptoms. That was a really good point. And one thing I was going to mention is, asking, I know that when I started out, and I think we've talked about this, using COW score just to educate, because what John just went through is really helpful. I didn't, honestly, I worked for 17 years and did not realize, hadn't really studied exactly what opioid withdrawal looked like. And I thought there was supposed to be a tremor, right? So, and I've heard nurses that I'm working with say, well, I don't really think they're in withdrawal because they're yawning. When yawning is actually one of the signs of withdrawal, or, they're just kind of bored, right? So I think recognizing what it looks like is really important, but then coming back to trusting the patient because the patient knows what it's like, and then asking their use history, because if they've been using methadone, I'm very careful. So asking about methadone was really important, something that I learned. Our one precipitated withdrawal in a long time happened to be somebody who didn't think it was important to tell us about methadone, didn't realize that they could get sick if they had just used methadone. So that's a really good point. And then I think it says, and are you going to touch on when they have not been on bupe for over 12 months, but want to start again due to craving? That's a really good question. I will, in terms of they might not be in withdrawal, or I've had patients who already went through the withdrawal. Like this is why sometimes basing it completely on COW scoring can be difficult, because I've had patients who went to jail and then were released, and then they were really just trying to protect themselves, knowing that they were going back out and could be exposed to the same thing. So I actually usually ask the patient their preference. So we'll have a discussion, and if they haven't used anything in 12 months, but they're concerned about craving, we might start a little lower and then give them the opportunity to build it up. Or if they say, no, I was always on 8 milligrams and that's where I do fine, great. So yeah, there is a ceiling effect on respiratory depression. So I do feel a lot safer in this medication. But I do give patients choices. At Highland, they call it the Subway menu. Patients can make choices for themselves, just like at Subway. So
I'd also like to add that we do have a resource on our website. I'll include it in the post-event email that talks about how to start buprenorphine after someone has already finished the withdrawal period. So great question, Tanya. Thank you so much for asking that. We'll include the information on that later.
Great. All right, so let's jump into the next case. All right, so case number 2, Roger is a 38-year-old male who presents to the emergency department with an abscess from injection use. He endorses the use of heroin and crystal methamphetamine. His last use was just prior to arrival. Roger reports fevers and chills at home, along with pain and swelling to his right buttock region where the abscess is located. He is febrile, tachycardic, and in severe pain. The team is concerned about sepsis. He is given hydromorphone for pain. Labs are ordered, an IV is established, and he ends up being admitted to the ICU for sepsis, and he has a consult pending for a surgical IND of his abscess. Okay, so Roger is taken to surgery, has the IND, and he recovers well postoperatively. The decision is made to discontinue the hydromorphone and taper down to an oral opioid twice a day. The plan is for Roger to be hospitalized for IV antibiotics for a period of time, 3 to 4 weeks or so. And he actually requests to have a substance use navigator consult in order to be transitioned to buprenorphine. So the son consult is completed, and the son recommends to have a consult with an experienced provider who knows how to transition patients from oral opioids over to buprenorphine. So about 5 days passed and no buprenorphine has been ordered. The patient has been hospitalized for a couple of weeks now. Roger is visited by a friend and is later found unresponsive in the bathroom. He overdosed on some heroin that his friend had brought him. He is resuscitated and all of the opioids are discontinued as far as anything prescribed. Roger then leaves the next day against medical advice without completing his treatment and without starting buprenorphine. So this is a case that we've heard of from several different bridge sites. So this is something that has happened multiple times, not just in one place, but it's unfortunate this patient didn't get especially the care that he was asking for. So I wanted to stop and consider, why did this patient leave against medical advice, and what things maybe could the team have done differently to manage his care? What do you think, Ariana?
So this case is really interesting, and I do hear about cases like this all the time. And I think there's a couple of different, there's a place in the middle where things can go wrong. So perioperative management of patients is, we have a resource for that on cabridge.org. This patient, first, of course, always stabilize the medical emergency. And at that point, the bigger medical emergency, Roger wasn't there, sounds like seeking care for opioid use disorder or withdrawal. It was because he was very sick and had this abscess. So stabilize that first. It was very appropriate to give high dose pain medication and to keep Roger comfortable, right? And of course, all names are fictitious. So that's appropriate. Patient during the course sounds like wanted care, wanted to be started on buprenorphine from what it sounds like. And that's cases we've heard all over the place. And sometimes it gets tricky in terms of transitioning a patient from full agonist opioids to buprenorphine. So the first thing in my experience is you don't have to rush it, right? You can wait till that patient is ready and you have time for a patient. I've seen these kinds of cases with patients who've come in with endocarditis, discitis, conditions for which they are hospitalized for a long period of time. So do you have time? Yes. But there's craving, right? So make sure you're either, one, adequately addressing the patient's pain, and two, adequately addressing the patient's craving. So if this patient's pain had, it sounds like they were tapered down. So were they craving? Clearly, yes, they were asking for help. And so, then that would be the time to transition, especially when they're asking for help. We call that like a transformative moment. You get this moment in time where somebody has some time to think about it and says, help me. And that's a great time to transition them. Tana, what do you think? I mean, I'm happy to talk about how we transition patients and the recommendations I've given before. But I think the other thing I want to address is your impression, like patients who leave against medical advice. I know historically, sometimes certain patients, I've seen patients who left and the nurse said, oh, fine, leave, or the provider who said the same thing. What's your impression of that in this case?
Yeah, and that actually leads perfectly into the next slide. And I do think that sometimes we have the perspective of like, oh, what a relief, that was a difficult patient, or they were irritable, or things just were kind of challenging for the healthcare team. And sometimes there's a sense of relief when that patient leaves. But I do want to remind us all that like every AMA is actually a threat to our patient's life. And I think getting down to the root of why that patient is feeling a certain way and figuring out how to treat it can make a huge difference. I mean, we see this all the time in the emergency department. Patients get frustrated or irritable because they don't feel good. And when we treat them with the right medication, they feel better. And they are very, very nice people. And it's very easy to manage their care once they are, not experiencing opioid withdrawal. So
sure. And I like to say, yeah, for this part, I've had similar patients like this where this went well, right? So when I've seen this go well, both at my facility and other facilities, is taking that moment and transitioning over to buprenorphine but reassuring the patient that you're still going to treat their pain, because that can be scary, right? If you're in pain and you're concerned they're going to put me on this medication and I still have pain. So having that reassurance that they're still at the center of care, patients may want to actually stay and get that kind of care. And I think the other thing is, so we've done this. In fact, we have, we're developing even more resources at cabridge.org, but I have done this inpatient by, making sure, sometimes I've put a patch, like a Butrans patch, to treat the patient's chronic pain, and then transition them fully over to buprenorphine. So they don't go a period of time without pain medication. So they have short actings, and then we do this like 8 to 12 hour transition over to buprenorphine, and then continue to treat their pain on top of it, understanding that if you give buprenorphine, and we've talked about this in other presentations, so I don't want to focus on this, but if I gave buprenorphine to somebody when they were receiving Dilaudid and were opioid dependent on those full agonists, I would precipitate withdrawal, which just means I'd make them feel sick because the buprenorphine is a partial agonist. So what we've done is been able to transition them over by going about 8 to 12 hours without a full agonist, and then getting them buprenorphine, and then continuing to treat their pain on top of it with full agonists after the buprenorphine is on board. So that's one way we've done it. I did want to, Katie Bell put out, Tana, you and I have talked about this before. Cravings measured on a scale of 0 to 10 is helpful. So like we have a pain scale, I absolutely agree with that. I think it's incredibly important to address somebody's craving. And that could have made a difference in this case, Katie, for sure. So I appreciate that feedback. And then the other question is, can buprenorphine be used for patients who use meth? So, so I'm assuming you're talking about patients who are co-using methamphetamine and heroin, and absolutely, Tana, you could probably comment on this, but I can tell you most of the patients that we're starting buprenorphine on also use methamphetamine in my own community and in communities I know around California. So.
Yeah, well, and we're seeing that a lot of the street drugs are being laced with fentanyl. So even patients who are using meth might have opioids on board as well. So that's something to be aware of as well. Let's see, Sarah asked, do you have an example of a craving scale? Is it just 0 to 10? Yes, 0 to 10. And then do you still start with 8 milligrams of bup? Yeah, that would just depend on the patient and their individual use. The hospital quick start algorithm just references starting with 8, but of course that can be adjusted based on severity of withdrawal or how much the patient uses or what dose they've been on the past. The provider can have a discussion with the patient and determine what would be the best starting dose. Do you have anything to add on that?
Yeah, and I was going to say, we do have some examples of order sets. I know that sometimes, this can be more difficult inpatient, right? So we do have examples of order sets, but we do tend to have a fairly patient-centered approach, because another thing is, if this patient was not, let's say we didn't give them enough buprenorphine and they were withdrawing and in pain, they might leave, right? So I think the whole idea in this case is exactly the slide that's up. Is every patient who's leaving against medical advice, that's a threat to that patient's life, and that is something to be avoided. So engaging the patient in their own care can be very powerful. Now, this patient, of course, we would, any patients who are leaving against medical advice, and I think everybody who works in a hospital setting has unfortunately seen this, and the reason they're leaving against medical advice is because their medical condition has not been fully treated. So really seeing that as, just like if we didn't get antibiotics for sepsis on time, or really putting it into that quality category where the negative outcome would be the patient leaving against medical advice or having a negative experience with buprenorphine. So if you have an order set that says they only get 8 and they can't have it for 12 more hours, they may need more. So making sure that there's something built in where the patient has a voice in this, that can be very helpful. But I do think having the, instituting a craving scale for patients who have opioid use disorder is really helpful.
Mm-hmm. Okay, so Elaine says, what was going on in the 5 days after the Sun consult? Was there any uncertainty to the patient about starting bup in the future? That's a good question.
Yeah, in my experience from different places where I've talked about cases like this, I think there's some inexperience with giving buprenorphine, some hesitancy in giving it. Really, historically, by calling the waiver in order to prescribe it an X waiver. So Tana started with language matters. Language matters as well within like the clinician team. So that has made it feel very scary. Like this is something maybe you shouldn't do. Whereas there's a whole history behind the X waiver, and in fact, we'll talk about that. But they just lifted a lot of this lifted the education requirements for a lot of these X waivers, especially in the hospital and emergency department setting, because this treatment is so crucial. So I really think that that's why we're here, is to really provide better education so that these cases don't happen, and that these patients, our patients who want help get the help they need and the help that they want in the time that they're asking for it. So I think there's various things that happen in different hospitals in that time, and some of it may have to do with discomfort of clinicians. So having a standardized way that you work within this and having this education ahead of time is really important.
Yeah, I agree. And I also think it's a moment to stop and remember that, as nurses, we can always help integrate our care team. Sometimes a substance use navigator consult might happen, and maybe the attending physician didn't see the note, or, sometimes with so many different providers integrated in one patient's care, things can get missed. So it's a good point to stop and remember that we as nurses are advocates for our patients, and we can stop and help pull the care team together and remember that, like, hey, this is what the patient needs. This is how we can engage them in care and treat what they're experiencing right now.
That's an absolute takeaway from this case, is that, it's a care team. And certainly there's different people in it. And I definitely think nurses drive care. I am definitely, I can't tell you how many times I've been saved by being surrounded with really talented nurses who see something that maybe I don't, or can introduce an idea that I didn't consider. So that's why we're here, is that nurses drive care. And I certainly think there could have been an opportunity here for somebody on the team to say, hey, let's get this done, let's, and have a mechanism that they can do that.
Yeah. Thank you. All right, let's go into case number 3. Ariana, this is you.
All right, so case number 3. So case number 3 is, so I hear about pregnancy all the time. In fact, one of my very first conversations with somebody on this was regarding a pregnant female seeking care. So this is Elise, a 32-year-old female, presents to the emergency department asking for help with heroin withdrawal. She's 30 weeks pregnant, started using heroin after a period of abstinence. She presents with nausea, vomiting, restlessness, diarrhea, yawning, and goose flesh. Her blood pressure is 150/90, and she's also currently experiencing labor and contractions. These are cases that make me really nervous because I don't want to deliver a baby in my emergency department. So initially she is sick. She's 30 weeks pregnant. Labs are ordered. She gets an OB evaluation in the emergency department. And there's a request for a quick transfer to OB for impending delivery. She is in withdrawal. So the ED provider orders buprenorphine 16 milligrams sublingually. So what happens? Her preterm labor stops. She's monitored overnight and discharged in the morning with a prescription for buprenorphine and clinic follow-up. Elise remained on buprenorphine for the duration of her pregnancy and delivered at 38 weeks. She was transitioned ultimately to a once-a-month injectable buprenorphine after delivery, and by report had done well. So this was a save. So this is a case. I think this shows that opioid withdrawal is a medical emergency, and that requires a lot of reframing, because unfortunately the narrative for many years was different. But we do know that opioid withdrawal is a medical emergency, and from this patient getting the right medication at the right time, this not only stopped her withdrawal, it sounds like her withdrawal may have been triggering preterm labor, but she actually was able to go home and complete a full-term pregnancy and then continue it on buprenorphine. So that, that heroic moment at that moment in time was really, really important. So, Tana, I'd like to get your your feedback on this case as well. What do you think?
Yeah, I think that's a really it's a really big testament to how effective bup is, in that the patient's labor actually stopped. Shannon, did you have any thoughts on that?
I think that the big takeaway from this is that with pregnant patients, people tend to be very hesitant with any medications, antibiotics, pain medications, so let alone buprenorphine that has, a lot of unfamiliarity among clinicians and providers. And this is just such a great case to show how effective it is. And I take from this, I applaud the ED provider who put in that order and the nurse who gave it before the patient went upstairs.
Yeah.
Yeah.
Rebecca says, is 16 milligrams a lot starting out? I usually start at 4 or 8.
Yeah, so that's a really good question, Rebecca. And Shannon, you can tell me your experience with this, but I say this very frequently. Number one, I call 4 milligrams the confusing dose. And I say that because it's sometimes not enough to treat a severe withdrawal. And other times it's enough to precipitate a withdrawal. And so that's why it's confusing to me, because if somebody does not get better, I am not sure if I precipitated withdrawal mildly or I just didn't adequately treat it. So, and I said this once while treating a patient, and I had a student with me, and then the person didn't get that much better. And my student reminded me that I called it the confusing dose. So I will either go much, much lower for somebody if I'm not completely sure that they are in withdrawal. This particular patient's pregnant, and what we do know is that pregnant patients do frequently require higher dose. And I think in this particular case, they were in really severe withdrawal and pending delivery. So I would imagine the clinician wanted to make sure that they were loaded with a really good dose of buprenorphine to really to make them more comfortable and to see how this changed their course. But Shannon, what's been your experience with some of the higher doses?
I agree. I mean, I think in a more typical setting, a patient who's not pregnant and, based on withdrawal, 8 is my usual starting spot, but there are times that I'll start higher. But again, given what we know about the OB patient with withdrawal, that 16 clearly in this case was appropriate.
I know that on our algorithm, we give 8 milligrams and it says wait an hour and then give 8. The more comfortable I've become with buprenorphine, the more people I've treated, I'm a lot more comfortable giving 16 to begin with, especially if a patient, and this didn't mention if this patient had previously, I didn't mention if they had been on buprenorphine, but if I have information that a patient has previously taken buprenorphine, I feel a lot more comfortable giving a higher dose for sure.
Definitely.
Yeah, along these lines with the pregnant patient, I know that with the higher metabolic rate, even just with their ongoing maintenance treatment, sometimes they may need to split their dose to 2 or 3 times a day or have a higher total daily dose. So just something to be aware of for those OB providers.
Yeah, and then just as a note too, this is gold standard medicine in pregnancy. So I think, of course, I think Shannon, you and Tana, you were both talking about, yeah, in pregnant patients, sometimes we are hesitant to give medications, right? But this is gold standard treatment to our patients with opioid use disorder. And in this moment, right, this changed the course for both mom and baby, and
Absolutely.
Mom was able to do much better. So I think it's just important to note that this is not just can be done in pregnancy, but this should be done in pregnancy. All right, I would like to, another thing from Rebecca. So, yeah, does it matter how far into withdrawal somebody is? It can. There's, if somebody's pretty early withdrawal, then, or if I'm unsure, I've had a patient who was actually only like 6 hours since last use, but they were experiencing some withdrawal and some pain. I started really low. I just kind of sprinkled it on. But if a patient is in really florid withdrawal, then I feel a lot more comfortable with a high dose. So I think those are some of those takeaways from case 3. All right.
Great, thank you. All right, so we're going to pause here. We've gone through 3 cases, and we want to hear from you. Are there any particular situations that you have faced or heard about at your facility that you want to talk about? And yeah, just put it in the chat. And if you would like to be unmuted to explain what that scenario was, we can unmute you. Whatever works best for you, we can do. We'll give everyone a few minutes to type.
Yeah, this is a time to ask any of those great questions if you've had any interesting cases that you would like to discuss. I feel like I always have cases. Because once you start doing this, yeah, I have to say, once you start giving this medication and really doing the right thing for patients, patients tell me so much more. So I learn from my patients so much, and have this drive to do the right thing for them. So you know.
Yep. I know just yesterday I was at work and a patient called actually first and was like, I'm in heroin withdrawal and I don't know what to do. And we talked about it and he came in and got started. It was so cool. I haven't had to call and ask before. So I was like, oh, this is awesome.
And I think that's important. You know, some of the takeaways from all of this is safety. Patients need to feel like you're going to have their best interest at heart, because, you know, I think you started, Tana, with a slide that says, you know, addiction is not a moral failing. This is a chronic medical condition that we can treat. And opioid withdrawal and opioid craving, right? Those are medical emergencies that we can treat. And if patients know that we're going to treat them with dignity, respect, and evidence-based medicine, that can change everything in the course of a patient's life. And really, the emergency department removes so many barriers, right? So historically, you had to jump through a million hoops to get this medication, to really get this treatment, right? So I think the takeaway from a lot of these cases is that you don't have to jump through hoops. You know, you can come in and we are going to treat you and make sure we have a plan for you, just like we do with other medical problems.
Yes, so true. Okay, so we're going to jump into the next case, but if anyone has any situations that they want to discuss, please put them in the chat and we'll come back to them. So don't hesitate to do that, but let's jump into the next case. Shannon.
Okay, so Jasmine is a 28-year-old female who presents to the emergency department requesting help with withdrawal from heroin. Jasmine states she checked into the local treatment facility thinking she could quit cold turkey, but now she's miserable. Jasmine is irritated, diaphoretic, restless with rhinorrhea. She has goose-flesh skin and she's nauseated. She also states she is suffering from diarrhea and abdominal cramping. She's curled up on the bed when you go in to see her and is yawning, can't stop moving, and is tachycardic at 118. That day, you're working with a provider who only works in your emergency department a couple of times a month. He orders 2 large bore IVs with 2 liters normal saline bolus, ondansetron, clonidine, and lorazepam. So after multiple attempts by multiple nurses to gain IV access without success, Jasmine is more frustrated. She's been injecting heroin for 10 years. Her symptoms are worsening and she's vocalizing her intent to leave. The nurse working with Jasmine remembers that buprenorphine is available in the emergency department, and she asks the provider, not the one seeing the patient, but another provider who's very familiar with using bupe, about this case. The 2 providers discuss Jasmine, and ultimately she's given 8 milligrams sublingual of buprenorphine, followed by another 16 milligrams. Jasmine leaves the emergency department without the need for an IV. Her heart rate's in the 90s. She feels normal. She's given a prescription and the next day appointment at a treatment clinic. She hugs you, the nurse, and says, "You saved my life." So this case, I think, is so powerful because it really, really highlights how impactful the role of the nurse is with these patients and how advocating for the for the patient can really change the course of patient care. Tana, what are your thoughts?
Yeah, this is amazing. I'm so glad to see that the team reassessed how things were going and the nurse advocated for a different treatment plan that ended up being the right thing for this patient. And I just love that the patient recognized how valuable this was. I've actually had a patient say this to me as well, a whole different case, but that is the most amazing thing, to be able to provide the right treatment for a patient and for them to see that it can completely change the trajectory of their life.
Absolutely. And I think that what's great in this case also is it reminds us, again, it's a care team.
Mm-hmm.
Yes, there was one provider caring for this patient primarily, but we're all working together. And for the nurse to feel comfortable to approach another provider and really initiate that conversation is fantastic.
Yeah. Excellent. Thank you. Brandy, did you want to come off mute and bring up a case?
Francesca, can we go ahead and try to unmute Brandy?
Hi, my name is Brandy. I just actually got a phone call from a son that's working on the coast, and he said he had a 13-year-old coming in. None of us have really worked with the younger group yet, and just kind of wanted to ask you guys your suggestions. He said that he read that a 13-year-old can't even start buprenorphine. I don't know if that's true or not. And we're just going to reach out to the youth center and see what their options are for this patient. Just unsure of, like, are there treatment centers that'll take a 13-year-old? It sounds like he's been snorting opioids and he's been doing Molly as well. Sounds like he's had a problem since January, so it's not like it's new. He's coming in POV by his mom. Just wanting to try to help my coworker out, and thought since I was in this meeting, maybe I could ask you guys.
That's a great question. I personally don't have much experience with the younger population, as you mentioned. Ariana, do you?
Yeah, I was gonna say, well, I know I haven't had a 13-year-old in my ED, but I do know that a couple of our sites have had some younger patients who, in that age range, who they have started buprenorphine. They've started this is reviewing everything with the patient if they're experiencing withdrawal. It's kind of, by definition, by the way, opioid use disorder is a pediatric disease. Typical onset of use, it can be like 12 to 14. So, and I think that so many people focus on prevention, but I mean, we have a 13-year-old who's snorting oxys, who needs help. So innovating and meeting that patient where they are at. I'd probably I might consider using a lower dose depending on their amount of use. There's not a lot of great studies for the pediatric population right now, but I always, for me, when weighing what to do, I try to figure, well, I mean, this particular patient is, at high risk of overdose. So if this were a patient I were treating, I would have a conversation about buprenorphine, and I would also find, I actually have ex-waivered pediatricians in my area too, to address this, knowing that by definition, addiction is a pediatric disease. So I think giving that patient an option, not excluding from that, would be appropriate.
The other thing to be aware of is consent issues with adolescents getting treatment. So making sure whether or not parental consent is required. If a patient is over 12 years old, they do not need parental consent to ask for mental health treatment. But as far as starting medication for substance use disorder, I believe you do need parental consent. Is that correct, Ariana?
Yeah, so the consent is tricky here. So it looks like parental consent is required for a minor's participation in MAT. I think Amy put that in the chat. This gets tricky, right? But yeah, I think that this would be something that you'd want to engage your team in, but again, give the patient some options. And when I've run into some trickiness with consent, I've had some really good conversations with my adolescent patients about that, and ultimately have found some shared decision making that from a healthier place. So But that's a case I'd probably engage some resources and make sure that you're also not just saying no to that patient, and making sure you're exploring the options with them. But I do know of a case of a 13-year-old who was started on buprenorphine in a very similar situation. And it was more, there was some time to, they were just really filling that out. But again, it's a little trickier because we don't have a lot of studies on the pediatric population. So
I'd also like to add that whenever caring for the pediatric population and the youth population, you're really also caring for the parents as well. So treating it like a dyad, like you have two patients, one that actually needs some sort of medical intervention and one that benefits from, some more of the soft skills, emotional support, teaching. It's a great way to approach it. And as a whole, California Bridge, we are putting out some youth resources in the near future. So those will be available hopefully soon. We recognize this is a very important population to reach. So we are working hard to get stuff ready for you all.
Thank you guys. I really appreciate the advice.
Yeah, absolutely. Okay, we are going to squeeze in one more case before ending with a Q&A. Okay, so Maria is a 30-year-old female who is brought into the emergency department by law enforcement for a medical clearance for incarceration. She appears to be in her second or third trimester of pregnancy, and upon assessment, she states she is about 7 months along and has not received any prenatal care. She is moved into a private room in order to assess fetal heart tones in the ED. And at this point, once she's in a more private setting, she reveals that she has been using heroin regularly for the last 6 years, and she occasionally smokes methamphetamine. Her last use was this morning. The RN at the bedside asks her if she is familiar with or has ever used buprenorphine in the past, and she says she knows about it but has never tried it, but she's definitely open to discussing that. The patient receives an IV, labs, a urinalysis, and a bolus of saline. The substance use navigator is consulted. She is watched for a couple of hours in hopes of her actually going into withdrawal so that she could just be started on bupe. She receives a second fluid bolus because she continues to have some slight tachycardia and is provided with a lunch tray. She then sleeps for about an hour. So no signs of withdrawal. She sleeps comfortably. She gets all the fluid and her heart rate comes down. She's medically cleared and released to law enforcement. So the RN actually receives a call from the medical staff at the jail a little bit later, and their first question is, was a UTOX performed? And the clinical staff were informed that a urine toxicology was not performed in the emergency department because there was not a medical reason for that test to be needed. The patient had readily admitted to heroin and meth use, and her symptoms supported that. The nurse encouraged the medical staff at the jail to start the patient on bupe if possible once she started experiencing withdrawal, and or to just bring her back to the emergency department to get started. The jail staff were somewhat hesitant, and that's kind of where things ended. So I think this is a good case to just discuss some of the nuances of navigating those patients who are in custody of law enforcement. And there's sometimes some extra barriers there, or patient privacy issues. John, what do you think about this case?
Yeah, it's a very interesting case because there's a lot of, patient privacy issues that go along with law enforcement, because again, they're not healthcare providers. They are law enforcement. So we cannot freely give them patient confidential information because they're not treating the patient. So, but again, even going back to the jail, the staff at the jail, it's like, you've got to trust your patient. I mean, this patient freely gave us the information that she was using heroin and methamphetamine. So definitely, the patient has the potential to go into withdrawals, even though she didn't have those symptoms while she was under the care in the emergency department. But again, each positive episode or evaluation that this patient undergoes helps ensure that this patient will get the appropriate treatment and be able to get treatment once she leaves jail. So the other piece is, of course, there's some law enforcement agencies that have intent to incarcerate forms that on the back of the form, it's like treatment rendered, treatment requested upon the jail staff when they get like any wounds, or, in this case, would putting buprenorphine 8 milligrams sublingually twice daily been an effective treatment plan if the patient went into withdrawal symptoms? Potentially, but again, the question rises to the fact that is the jail comfortable and can somebody safely give it there?
Right. Yeah, something that one of the statistics that was staggering to me is knowing that people who are actually incarcerated are at a risk for death from overdose 100 times greater than the general population. So I've always been, ever since I learned that, I've been keeping that at the forefront of my mind. So those patients that I interact with who are in custody of law enforcement, encouraging them to return for care if they need it, and making sure that they know that the emergency department is a safety net for them, whether or not they get care now or they come back upon release, whatever that may be, trying to support the fact that, making sure that they know that we are there for them whenever they may show up.
That's 100% accurate.
Any questions, or do any of the other panelists have thoughts on this case?
The only thing I was going to add was just that, yeah, I think, or I don't know if adding, but when patients are not treated with buprenorphine with reentry, there's this enormous rate of overdose and death, and always, I talk to my patients about that, and so in this particular case, it's tricky, but I would work with your local jail to see if they are giving buprenorphine. I would absolutely advocate for that so that they already have a program. And if they don't, make sure it's well known that your emergency department or wherever you're working is would like to see patients have a program for reentry where they can get buprenorphine as well, just because clearly with abstinence model and loss of tolerance, if folks go back to using what they did before, there's that high risk of death, overdose and death. So I think just making sure you're having conversations with your patients too in your local jails.
Thank you. Okay, so I know we'll just jump into some discussion and Q&A if anyone else has any burning questions before we wrap up. Amy, did you want to say anything?
Well, I just wanted to point out, Marie asked a great question about what sort of resources if the jail medical team refuses to recognize their problem. And, there's no easy answer to that. There's a lot of nuance involved engaging with law enforcement. I invite John or Ariana to join in. I imagine, John, you have encountered this a handful of times, so I'm curious if you have any insight.
Yeah, and that's the point of having the conversation with the patient prior to them leaving, is that if you do go into withdrawals, the jail has a responsibility to treat that. And if they're not going to treat it in jail, they have to bring you back to the emergency department. And that time we can initiate buprenorphine therapy. But I would have that conversation with the patient before they leave and make it clear to them that this is an option for them to come back, because if the jail can't take care of them, they must come back to an emergency department for stabilization.
Right. Yeah, I often have the same conversation with patients. And then also if I'm interacting with the jail staff, trying to kindly remind them that this is best practice treatment. And this is how the evidence has shown opioid use disorder should be treated. So sometimes, equating it to, a specialty consult. So does the patient need a neuro consult? And would they get treated for whatever neuro condition they have that requires a specialty consult? And if so, then they should get this treatment as well. This is just like any other medical condition.
I agree, Tana. And remember, it's like this is a chronic disease, just like diabetes or hypertension, that needs treatment. So, this is something that all providers need to understand.
Yeah.
And I would suggest also that often with the medical staff at your local jails, they just may not be educated regarding this, be familiar or comfortable, because we know in the mainstream emergency departments, there's many providers who aren't comfortable. So, provide that good information, like Tana said, it's evidence-based, provide them resources, encourage them, build their confidence, and that may help build a better partnership.
Yeah, exactly. And we do have a resource about helping or caring for patients in custody. So I'll include that in the post-event email. We did have two questions. One of them going back to the question Sarah posed earlier about methamphetamine use. It seems like the clarification was regarding if buprenorphine can be used to manage the methamphetamine cravings, or if it only had to do with the history of opioids as well.
Yeah, so I was trying to, maybe I didn't answer it in chat to everybody. So if a patient's a strictly methamphetamine, no opioid use disorder, then we don't treat them with buprenorphine unless if they endorse any history of opioid use disorder, then I have found buprenorphine very helpful, especially for co-use. For patients who are strictly methamphetamine, there's a couple of projects going on and you can find some evidence. I don't have the links here, but many of us are using mirtazapine to decrease craving. There's not great evidence. There's a couple of studies that were previously done, and I think that's the best evidence we have, that and contingency management maybe. But there's also a study that just came out that was combined naltrexone and bupropion to treat patients. I can tell you that in my area, I am finding that there's fentanyl in the methamphetamine, so I'm very hesitant to give anybody using meth naltrexone. Just because I'm really concerned about precipitating withdrawal. And I actually had a patient recently who thought they were having a pyelonephritis, a kidney infection. And I actually did use buprenorphine because we did determine it was probably fentanyl withdrawal. And that individual didn't realize that that there was fentanyl in their methamphetamine. So anyway, so there is some room for that, but the evidence really is in mirtazapine and bupropion and naltrexone.
Thank you, Ariana. Our niece asked a question about what's the best way to educate ER nurses on the role of a son, buprenorphine, and to help them be more knowledgeable about the program. And the answer is coming here. And Tan, if you want to go to the next slide, we've got a link to our resources on our website. We have a ton of information available, and we're available for technical support. So there are sites that are currently listed and supported, but we're also open to supporting other sites. This is powerful, important work, and we want to help you all. So you can use a QR code here, or you can go to cabridge.org. If you click to the next one, there we go. We've got an opportunity to request technical assistance right there. And you can also access this directly through the website. But we want to hear from you. We would love to support you in whatever you're trying to navigate. And if we need to arrange for nurse-specific trainings, we can absolutely do that. So please get in touch and let us know. And we have a training coming up in September, and that is going to be transforming. If this is one we're actually really excited about, not that we're not excited about all of them, but this is about harm reduction. And this is a huge place for nurses to really take an extra step in advocacy and caring for their patients. We will be having Charles from the National Harm Reduction Coalition joining us, as well as Josh Luftig, who is part of the California Bridge family. And we'll be exploring how harm reduction and emergency department nursing really is a perfect match. So again, thank you all for joining us. You can register on our website. And if you head to the next slide, Tana, shows where you guys can all keep in touch with us. So we've got all of our different social media ways you can get a hold of us. And yeah, thank you guys all for being here. We're really glad you're able to join us. I'll drop the link for the training. And we'll hang out for just a minute if anybody else has additional question they want to join, want to share. Yes, Rebecca, we hear you about adding this to my journey. We are working on creating modules with that exact intention to have it be part of the regular training that happens for all of the nurses at different sites.
I was going to add, in terms of training nurses, sometimes it's hard because it's shift work, and people, especially in the emergency department, when they're off, they want to be off. You know, that's why many people work in the emergency department. So if that's the case and you're having some trouble with engagement, I started showing up at meetings. And that's a good way to go because you're already capturing your audience and then normalizing the conversation. So I just wanted to add that in. We actually we called it, we went on tour. we would just show up and do like 10 or 15 minutes or sometimes 5 minutes if that's all we had, and just tell nurses all over the hospital what we were doing, and the response was really positive, and it reminds me that we should go on tour again.
Yeah. No, I totally agree. Attending staff meetings if possible, and if you want to engage our team and have it be a virtual attendance and we present some information, we can do that. Or if it's just if you're a substance use navigator or you're a nurse educator, go to the staff meetings. And then also just modeling good language, modeling that's what I do when I'm on shift, as the charge nurse. I model the language choices I talk to the nurses about, oh, are we going to try getting them on buprenorphine? And we just talk about the treatment so that it casually helps educate nurses about what we're doing.
Yes, and next level stuff is that Tana is currently working on developing some modules for education. So much like nurses learn in other ways, for other disease processes, maybe you've done a sepsis module, maybe you've done a cardiac module, developing modules for substance use disorder, opioid use disorder, to normalize what we do. So we're hoping, we're evolving. So with more and more resources.
Great. Thank you all for joining us today, and a huge thanks to all the panelists for sharing your clinical knowledge and discussing all of these with us. Again, thanks everyone for being here. Brandy, if you want to send me a message directly, we can help you and your youth patient if needed. So please know that that is available to you.